Good afternoon, folks, and welcome to another edition of An Hour with Bob. This is going to be an interesting show today. We're going to help out health. We're going to talk to a thoracic, let me get this, a cardiothoracic surgeon. Is that correct, huh?
That's very good.
Miss Gleeson? No, it's Gleeson, right?
Gleeson.
Gleeson.
Yep. Yeah.
And so I said it right, huh? I got it right, and that's without even looking at notes.
Yeah. That's good. That's good.
Now, where are you from originally?
I'm from Michigan originally.
Oh, where? What part of Michigan?
North Branch. You got to do the classic hand. It's in the thumb
God,
area.
Yeah. Wait a minute, the classic hand. This way or that way? Closer to Detroit or
closer to, well, it's the thumb area, so closer to Flint.
Oh, okay. That's
but yeah, Detroit area.
And just the reason I say that is I used to go visit a friend in Niles, Michigan, which is all the way on the other side of Michigan.
Yeah.
So when you said close, I didn't know what you were talking about. Closer to.
Yeah.
You ever been to that area, the west coast of Michigan?
Yeah. The start of my practice, my private practice, was in Battle Creek, Kalamazoo area.
Oh yeah.
So Cereal City.
I was just going to say that.
Yeah.
Cereal City, Battle Creek, Michigan.
Yeah.
Yep.
Yeah. So, and I did a lot of my training, actually, all the way from third year medical school to fellowship. I did all my training in Detroit.
Oh, no kidding,
Yeah.
Wow.
Yeah, so.
Have you ever been to Silver Lake, Michigan?
No, I have
Silver
not.
Lake, Michigan, they have a dunes there. It's like 300 feet high. It's the coolest thing. I've done it twice. I've just flown out there just to do the dunes. It's crazy.
Really?
Oh yeah, they get the dune buggies and you go up and down the hills and you go as fast as you want.
Yeah.
It's pretty cool.
Funny.
And it's right at the water.
Yeah.
It's right at Lake Michigan.
Oh yeah, which is gorgeous, right? I mean, Michigan's a beautiful state.
I get a lot of people on the trivia question. This is called the Ocean State, Rhode Island.
Yeah.
Because we have a lot of coastline.
Yeah.
But do you know what a question I get a lot of people on is what state has the most lights?
Well, it's.
What am I thinking of?
Are you talking about lakes?
No, lights. Lighthouses. I'm all messed up today.
Oh,
lighthouses. What state has the most lighthouses?
I'm going to say Maine.
Maine? See, I would have said Florida. Or California, coast, something with a lot of coast. Mm-hmm. It actually is Michigan.
Oh, really? I did not know that.
Yeah.
I did not. I would not have guessed that.
No, nobody does. Nobody gets it.
Yeah.
Nobody gets it.
Interesting.
Because you got Lake Huron there. Mm-hmm. You got Lake Michigan.
Yeah.
And I think you get Lake Superior too, right?
Yeah.
They have the most. I was shocked to find that out when I was.
Yeah, I would not have guessed that.
I'm very big on geography, and I went out there specifically to tour the state and tour around the state.
Yeah.
Then I went over to South Bend, over to Notre Dame.
Yep.
Visited Notre Dame.
It's very nice.
Yeah.
So you've been a lot to the Upper Peninsula, or?
I've never been to the Upper Peninsula.
Mackinac Island.
Right. Mm-hmm. Oh, they got that big bridge now that goes over there, right?
Yep. Yeah.
Have you been up that way?
Yeah.
How long? That's a long ride, right? The bridge itself.
It's, I'm not sure how long over the bridge, but I know from home, so to speak, up to the Upper Peninsula is at least 8 hours or so drive.
Yeah, it's a big state. Michigan's a good-sized state.
Yeah. I only said Maine for the lighthouses because I did like a sailing trip around Maine, and obviously we visited all the lighthouses, so it just seemed like there were quite a few. Yeah. So I'm interested.
Well, people would say Massachusetts too is another one that has a lot of coastline.
Yeah.
But no, it's Michigan. It's your home state.
My home state.
Your home state.
And I got it wrong.
No, again, in your defense, I say that to anybody, if somehow Michigan comes up or something, we're talking about coastline, whatever, and I'll throw that question to them. Nobody gets that.
Nobody gets it. Well, good. I don't feel so bad then.
That's right.
Yeah.
So where'd you go to school?
I went to University of Michigan for undergrad, but then I left Michigan and went to Missouri to Kirksville College of Osteopathic Medicine for medical school. And we do our first 2 years. So Kirksville is more of a small town in Missouri. I'm not sure how many people. I think both schools actually were the most population of the city itself.
Really?
Because there was also a liberal arts school in Northeast Missouri State. Right. So you do your first 2 years there, and that's when I came back to Michigan and finished the rest of my training through different hospitals in Detroit. area.
What's the big difference in school sizes, huh? Michigan State's a big school, right?
Michigan, yeah.
Michigan and Michigan State,
Yeah.
both big
Yeah,
schools,
huge.
real big schools.
Yeah, and it's definitely, I don't want to say a culture shock, it's definitely different because it's more of a farming community in Missouri, and so you would literally go to what we called Wally World, which is really just a super Walmart, right? And it was the biggest store, and you would go to, we called it Wally World, and you would have trucks in the parking lot that would have pigs in the back of their trucks and stuff.
Oh, really?
And some of my friends from like Chicago or whatever that went to medical school there were like, is that a real pig?
Oh, they've never seen one, right?
They'd never seen one
That's
before.
unbelievable. Isn't it weird how city folks versus country folks? Country folks never saw big high rises and elevators and all that kind of stuff.
Yeah.
It's weird how the difference is where you grow up.
Yeah.
Shapes you.
Yeah,
right?
It is, and it was a great experience. Definitely a great location. You couldn't do much, so all you could do was study. So
Exactly.
there wasn't much to do.
And I would suggest that why would you send your kid to like Florida State or something, or UCLA or something, where it's always nice out and they can be outside doing everything other than studying.
I would say, yeah.
Whereas send them to Vermont or Maine or something, or Michigan or Minnesota, where they can't. Actually, they had snow in Minnesota the other day again.
Oh yeah, and I think Michigan did too, because my family still lives in Michigan, and I talked to my mother very frequently, and she said they had snow, which is sad.
How many in your family?
I just have two older brothers. My dad had passed away, probably 8 years ago now. So.
Oh, sorry to hear that.
Yeah. So he had passed away from small cell lung cancer. So lung cancer, of course, is what we do a lot of in my profession. So
right. Yeah.
So a lot of what I do is focused on that.
Well, it's interesting in talking to you about that because I found out I have a little issue in it was an existential.
Interstitial
lung disease, they call that?
Yeah.
Among other things?
Among other things. Yeah, exactly.
My 5 knees?
Yeah.
I've had the same knee replaced, actually, 3 times.
Oh, that.
Langworthy did the last one.
Yeah.
The first one got infected.
Oh.
I spent 86 days in an extended care facility with a massive infection. I was on IVs for 47 days, twice a day, an hour each time. And then they put a new knee in, and I left the hospital too soon to go help a candidate running for, at that time, lieutenant governor. Now he's the governor.
Yeah.
And we were successful in the election, but unsuccessful with the knee because my knee ended up dislodging from, or should I say the what's the big bone here?
The femur?
Femur.
Yeah.
Femur detached from the knee. And when I first met Dr. Langworthy, I go to the appointment to see him, and they had already ordered a MRI, and he goes, "How long have you been dealing with this?" I said, "Well, I had the other knee in July, and this was the following September.
Yeah.
So we're talking 14 months.
Yeah.
He said, "You've been walking around 14 months like that?" I go, "Yeah." He says, "Doesn't it hurt?" I said, "It hurts a lot." He goes, "I deal with Navy SEALs. They'd be crying. They'd be falling on the ground crying." He says, "Doesn't it hurt when you stand up?" I said, "It hurts like hell." I said, "But after I stand up, I'm not too bad. It hurts, but I can deal with it because I've had 5 back operations, so I know what pain is, right?"
Yeah.
He goes, "I can't believe you're even walking." He says, "Your knee is not connected, or your femur is not connected to your knee." And he did the last operation.
Oh, okay.
But before the operations, I had knees shot, what do they call them?
What, just the injections? Or?
No, before the injections. Shall I say after the injections? First the injections, and then I had, what the hell's meniscus.
Oh, okay.
I had the outside meniscus done and did the whole physical therapy for weeks. That didn't work. Then I went back in. Oh, it's got to be the other side. Did the other side. 6, 7, 8 weeks physical therapy. That didn't work, and then they said, "You need a new knee." And I got the new knee, and that got infected. That was the first. Yeah, that was the first one.
Nice.
First and second one, not good.
No,
not good. Langworthy's the only one that did a decent job.
I'll let him know that.
I have. I have numerous times, actually. I think. Yeah, I think I have. I think I have.
He's a very good orthopedic surgeon, very well known in the area. Actually, he and I worked together in Battle Creek, Michigan, which is how I found out about a job here when I wanted to move out east. So, but very, very talented orthopedic surgeon.
Right.
Does a lot of research, a lot of papers, a lot of.
Oh, he definitely is into the research. That's for sure.
Yeah.
I went to Cuba with him.
Yeah, that's what you were saying earlier.
Yeah.
What did you guys do in Cuba?
Research.
Research. Okay.
At least that was the premise.
That was too funny.
And we went over there at the time Trump had put an embargo, said nobody's allowed to go to Cuba.
Okay.
And that's when we went over there.
Okay.
And I said, well, wait a minute, you got this guy from the CS, I'm not going to say the names, but 3-letter words. 3 letters, I should say, after the name. There were 7 other people I was introduced to. They all had 3 letters after their name, except for the Navy SEAL that was with us.
Yeah.
I'll say one, the MI6 guy. There was a guy from England. And I said, oh, well, wait a minute. I'm the only one without 3 letters after my name. They said, well, you're the documentarian. And we arrived in Cuba in the middle of the night.
Interesting.
And the whole thing was clandestine. It was pretty interesting.
Cool.
And we were there over a week.
Oh, really?
Yeah, yeah. We left from Key West and we shot over there. And like I said, we got there in the middle of the night. And I didn't realize, up until that point, and thank God I had a Navy SEAL and an MI6 guy on either side of me. The 3 of us jumped off the back of the boat. We're halfway over. We decided to stop the boat and go take a dip.
Yeah.
We jumped in the water. Then he dragged me down. I didn't know that. I didn't realize that. An artificial knee is heavy.
Yeah.
And you're swimming like this. And it was hard to keep up. It was hard to keep afloat.
Interesting.
I would have not survived. I would not, because when we all dove down, and we all came up, we were, 100 feet from the boat at least.
Yeah.
Because the boat was also drifting. And I couldn't have made it back without the guys.
Really?
Yeah, it was scary. I didn't know it to that point, that knee. And then when he ever showed me a knee, and you feel it, the damn thing's heavy.
Yeah, it's very heavy, yeah.
So it throws your whole body off. Yeah, and I didn't like it. I didn't like that feeling. I'll tell you that. So no more swimming for me, that's for sure. No more swimming for me.
Just wade.
So how did you get into your line of work with the robots? How did you get into that?
Happenstance, actually. So I trained cardiovascular and thoracic. So in practice, I did vascular surgery, endovascular, and non-cardiac thoracic surgery. And when the robot was coming out, so I trained in Detroit. Henry Ford Health System is one of the huge hospitals that started with the robot, the initial Da Vinci S for prostate surgery.
Now, the Da Vinci robot, I'm aware, I don't know much about it, but I've heard about it anyway.
Yeah. So Intuitive Surgical, and if you look at a map of like the number of robots in each city or location, Detroit is exponentially a large number of robots. And so I was exposed to it early in training.
Right.
But it really was just urology, doing prostate surgery. It wasn't expanded anywhere near vascular or thoracic region. But then out in practice, I was with a group, Vascular Health Center, where I was the only thoracic surgeon in the region in Battle Creek, Michigan, but I had vascular surgery partners. And I originally looked at the robot after a conference for our vascular surgery to do aortic surgery. And my older partner looked at me like I was crazy.
Really? What said that you were going to switch to that?
He's like, no, I don't want to do robotics. And so I sort of switched gears. I went to a conference in Texas, and I was the only thoracic surgeon at this robotic conference.
Right.
That was made of urology, gynecology, some general surgeons.
But they were all robotic surgeons?
They were all surgeons interested in robotics.
But all different fields
of robotics. All different fields.
Yeah.
And there was one thoracic surgeon presenter and me from the thoracic surgery component. And he had nothing good to say about robotics. And so this is probably in 05, 06. and you're considered an early adopter, you know, within those years.
Right.
And our hospital system was picking up a robot at one of the smaller hospitals for the urologist. And it was the original Da Vinci S. And I've experienced all versions of the Da Vinci, right? You know, so I was an early adopter, and I decided I'm going to do it for thoracic, because my partners definitely did not want to do it for vascular.
They didn't like the idea.
They just had zero interest. And it was painful. It was painful to start robotics, because it wasn't meant for lung surgery. It was,
Why not? Why not?
The instrumentation was strictly, you know, it's newer instrumentation. So it was strictly for everything in the pelvis, which we knew it did very well in those smaller spaces and dissection. We knew with prostate surgery, after you went through your learning curve, so to speak, patients just did better, their blood loss was less, so on and so forth. And so it only made sense to convert to robotics for thoracic, but you had to go through the sort of the advancements in robotics to really see what we have today.
Then, right?
Yeah. So it was a lot different. I tell people, you know, I experienced the S was the original, then the SI and all the upgrades of the SI, and now we have the XI, and we do have the XA at South Coast where I am now. And easily, if you look at just the advantages for the patients,
well, less cutting, less invasion, right?
Yeah, so it's, and less hospital stay. So you go,
right, of course, yeah.
I trained in the 90s, so in the 90s we were still doing open surgery. For, so if you just look at lung cancer patients, we were doing the big open incisions. Some of my mentors were cutting the rib, taking the rib out, you know, even back in those days. And then half of my mentors were starting to do thoracoscopy, like the—
What is that?
Thoracoscopy is still going into the chest with the camera, but it's more rigid instruments. A little more cumbersome. You know, your vision is looking at a TV monitor while you're doing the surgery, whereas with robotics, you're at a console. So you have the ports, you know, same thing, camera, everything attached to the patient. Then as a surgeon, you go to the console. But in the console, your vision is magnified, and you have this 3D vision.
Right,
so
and it's in color too, right?
Yeah, so it's an easier dissection from that component, and you have more manipulation ability with the arms.
Were you good at video games?
I didn't do video games. Everybody asked me that.
Well, it's gotta be. You would think there's a correlation, right?
You would think so.
Games, you know, playing the games and the joystick, and because you use the joystick, right?
It's like that. I mean, it's like two little handles underneath the console that you're manipulating with your. It's like driving a car, right? You know, you have a brake, you have the pedals to advance and zoom in, zoom out with the camera and adjust the instruments. So it is like that, you know. And I grew up, you know, in the 80s where my cousins had Atari, and we would play Pac-Man and stuff, but that's about all I did.
And you must have beat them, right?
No, I did not.
You didn't? No.
I was not the best at video games. You know what? The Pac-Man, Donkey Kong.
Right. Yeah.
I think it was, and Tetris. Yeah, I wasn't that good.
No.
I'm much better with the robot.
Oh, good.
Much better.
Now, how do you practice on the robots? How do you get you? Do they let you go in a room and have the robot to play with?
Yeah, so when I first started using it, there were like training that the company would send you to, like for a day or 2 days. Back when I did it, it was cadaver labs, really, where you would put in the ports, dock the robot, and do surgery and different manipulations with it. And you had to do so many hours. But then once you're in practice, because we were already doing minimally invasive surgery. So you're already doing thoracoscopy, you're just converting to a robotic platform. So you're really not changing anything. You already have the skill set. So it's not really training per se, it's just switching to a different instrument type of thing. So now I do hundreds of cases every year, so it's not like you need practice. I'm doing hundreds. I've done thousands of cases, so.
Wow.
Yeah, so it's a nice platform to see, just to see the advancements for thoracic surgery. And if you just look at specifically lung cancer surgery, from the days of doing open surgery where patients were in the hospital for a week,
Right.
and then switching to thoracoscopy where you got them down to, maybe 5 days, and then you keep cutting time, right? So as the robot has advanced
Yep.
more for lung cancer patients or cancer patients in general for the chest, now our patients go home the next day.
Wow.
So the length of stay now is down to 1 to 2 days for those procedures. And the outcomes are just so much better. I mean, all the advancements we have for our cancer patients have definitely changed as far as instrumentation for the lung, where it's just safer for the lung tissue, less nerve damage, less blood loss, less time under anesthesia. If you look at time from, some people do an open surgery and it takes them 4 to 6 hours.
Right.
My cases now with the XI robot are down to an hour and a half.
Really? Wow.
So it's significantly less time for you as the patient under anesthesia.
Right.
So you have less risk to your lungs and pneumonia
Sure.
and all those complications that you can see after. It makes a huge difference.
Now, what's the difference between, I thought lung was pulmonary, right?
Yep.
Now, what's the thoracic? I thought that was the throat. No?
Well, we deal with everything from like the chin to the diaphragm. So we do, most general or non-cardiac thoracic surgeons will do any gastric type of surgery, esophageal, tracheal surgery, anything around the heart tumor-wise, as well as the lungs, but not open heart surgery. Like I don't do, coronary artery bypass or valve surgery or things like that.
Oh, I need a valve, by the way.
I won't do that for you.
You won't do it? No. I thought I'd get a discount.
I haven't done valve surgery for 23 years.
Really?
It's been a long time.
Wow, you've been a surgeon that long?
Yeah, I've been in practice for over 20 years now.
Wow.
Yeah. And I think the last time I did, the last time I did any open heart was as a fellow, so that was back in 2001. So yeah, it's been a long time.
Wow.
Yeah.
Now, when you see, we'll get back to this heart thing in a minute, but we're at the cancer in the lungs. Is it usually in the lower lobes that they get cancer in the lungs?
No, you can get it in any lobe. I think the most common location is usually the upper lobe.
Oh, it is,
classically. But you can see it anywhere in the lungs.
And what does it look like? What does cancer look like?
Uh,
Color-wise, that's it.
It's sort of white, marbly color,
See, I
very,
thought
like,
it would be red for some reason. I don't know why.
Not necessarily,
No.
but different types of cancers can have a different appearance. But if you
Black
look
or
at
red.
most of them, they're usually like a marbly black-white type of coloration in the lung itself. So, and usually more firm. Sometimes the center portion is a little more crumbly, so to speak, if you cut into it and actually look at it.
Now, when you cut into it, how do you get rid of it? How do you get it out?
Well, classically, we're not technically cutting into the tumor itself, so you're really removing a section of the lung tissue. So our lungs are in lobes. So your right lung has 3 lobes, an upper, middle, and lower,
Right.
and your left lung has an upper and a lower. So let's say you have a tumor in the right upper lung, and you have good lung function going into surgery, you're a candidate to have that entire upper lobe removed.
Right.
So you're
Still got 2 lungs.
so you still have 2 lobes, and then you have your left lung. So most people can tolerate that very well, but there are certain criteria we look at before we decide to do surgery, because with smaller tumors you can do just like with breast surgery where you limit the amount of tissue you remove, you can do the same thing for the lung where
Right.
you're doing what's called a segment resection or segmentectomy. So you conserve lung tissue. So you can say, hey, I'm going to remove the apical segment of your right upper lobe, so you have the rest of your upper lobe as well as the middle and lower lobe. So you conserve lung function without sacrificing your cancer outcome.
But again, how do you get the parts out of the body? Because you're only going in with you're only putting small holes in, right?
Well, you have to put it in a little bag. It goes in a bag, and you pull it out through one of the port sites.
Really?
And you, the vast majority of the time, depending on the size, of the amount of tissue you're taking, you have to extend one of your port
Open
sites
one
to
of
about
them.
like an inch in size in order to pull it out.
Which is your body part, folks.
Yeah,
Right? You
it's
open up your something,
Yeah,
right?
yeah.
You make
Yeah.
it, but it's still a hell of a lot better than cutting your
Oh yeah.
whole side up, right?
Oh yeah, yeah. Well, shoot. I mean, even in training in 99 and 2000, I had attendings who we were still making incisions literally like from here all the way to your back and
Right.
wide open,
Wow.
and yeah, it makes life easy.
Oh,
The surgery is
God.
very easy,
Yeah.
but the recovery is so debilitating, especially when you had some of those surgeons, cutting a rib on purpose or taking out a rib in order to get better
Yeah,
visualization.
he's got big hands,
Yeah.
especially guys got
Yeah.
big hands. I had that problem with a back surgeon. Seriously.
Oh.
He cut out too much of my lower spine just to get his fingers in there, I think. That back in the day, 1975.
Oh goodness, a long time ago.
Yeah.
Yeah, times have changed. It's amazing. Number one, once you like seeing Intuitive Surgical and the Da Vinci robot, and just the maturation of that and the advancement of technology, and seeing where it's going to go. Because people ask me, like, why did you do it if it was so painful to do for thoracic surgery? And I talked to
What do
other
you mean so painful to do? You mean
like
to
in the
study
olden
for it?
days, no, just the instrumentation, it took
Right.
longer. So you have to remember back in, the 90s, we didn't have stapling devices for the robotic arm. So you had your assistant coming in to staple, the pulmonary artery or the
Right.
vessels to the lung, so on and so forth. And it was more difficult and more cumbersome. Or if you had an inexperienced assistant, you're going back to the table, back and forth from the console to do your own stapling or setting everything up
Right.
so you're doing your own stapling. Now we have, the XI has stapling device for the blood vessels, for the lung.
So you do the whole thing yourself?
I do the whole thing. My assistant at the table literally just has to exchange out instruments for me. It really is so much faster, and it's
and more precise,
and more
apparently.
precise, and the complications are significantly lessened with it, and patient outcomes are very good. So the whole goal was early on looking at lung cancer, just talking lung cancer strictly, open surgery versus thoracoscopy. Is the cancer outcome equivalent? So there are a lot of studies that have looked at that. And yes, you have equivalent lymph node dissection rates, you have equivalent cancer outcomes, whether it's open or thoracoscopy.
Right.
Well, then fast forward to robotic versus non-robotic, minimally invasive surgery. Are those equivalent as well? And we can definitely say yes. You are not sacrificing cancer outcomes. And there are some articles that are actually saying, robotic is superior to regular thoracoscopy.
Right.
But I think overall, because you have, surgeons who do both, right? Some surgeons stay with the thoracoscopy or the non-robotic platform. It comes down to your preference. Like, what
Right.
is your skill set? What is the best technology in your hands as a surgeon, without sacrificing patient outcomes from a cancer perspective specifically. And I think you're not wrong either way, but minimally invasive is definitely the way to go now and further in the future.
Oh, I can believe that. That's for sure.
Yeah.
I remember my first back operation. I had to cut like 18 inches up my back. Now they're like that big.
Yeah, yeah. Well, and now you have the 7D surgical system for neurosurgery. You have robotics for neurosurgery. Same thing for orthopedics. You have the Mako robots as an example for robotic knee and hip replacement. And I think they're also coming out with robotics for shoulder surgery. So it is definitely the future and getting more accurate outcomes for patients.
Well, there's no shaking of the hands, right?
It takes all that away. Yeah. So if you're,
If you're a little shaky. You're a little shaky.
If you're a surgeon with tremor, it definitely takes it all away.
Did you hear about that? Well, how long you been in Massachusetts?
I've been here 7 years.
Did you? Well, you were probably here when the guy. I think it was in. I won't say the hospital, but it was a hospital in Massachusetts, where the guy left the guy cut open while he went to the bank. Did you catch that one?
Oh, I heard this story.
Yeah.
But I don't know the details.
He was doing a back surgery on the guy, and he said, "Hold him up. I'll be right back." And he was gone for like an hour. he went to the bank to get a loan or something, do something, and he didn't just go there to make a deposit either. I mean, he was in there a while, and they're looking for the guy all over the place. Oh, I'm pretty sure he got fired.
Oh, I would assume you would get if not fired, at least a massive amount of trouble for that.
Yeah, you would think, right?
Yeah.
I mean, he could have killed the guy, or certainly get him a bad infection.
Yeah, that's a little risky. Yeah.
Leaving somebody cut open that long.
Yeah.
Now, did you run into any problems? Now, obviously, you said you've been doing it over 20 years. As a woman, going into robotic surgery, was that any strain on that? Was any
Not
extra
necessarily.
strain for
No.
you? No.
No. It's. I think I was very lucky more from the start. I know a lot of female surgeons, especially, and there's not many of us in cardiothoracic surgery compared to other surgical specialties. Talk about the obstacles that that they've endured, so to speak. I was sort of lucky. I trained in Detroit, and I got into a program that was a smaller program. It didn't have the tier type of system, where you could only do, you're basically a scut monkey as an intern, and each resident year was restricted, that kind of thing. We didn't have that. I was one of 2 residents to start with in my general surgery program.
Right.
And even
They let you do it all? They let you
jump
right in?
at Detroit Riverview, even as an intern, I was already doing some surgeries. So as an intern, they let me do laparoscopic cholecystectomies, and we did appendectomies, smaller procedures,
right.
Obviously with an attending there. But so by the time I started residency, it really came down to, I was lucky. I grew up in a family where work ethic was huge, and so,
right.
And I also trained in an era where you didn't have these restrictions of 80-hour work weeks or things like that, where you could work as much as you wanted.
Really?
Where I would stay days and days in the hospital just to do surgery.
What do you mean, the restrictions? They have a restriction for 80-hour work week?
Yeah, so they started back.
But that is a long week, 80 hours. That's two That's 2 jobs.
Yeah. I mean, I grew up. I trained when I could work. I'd be on call as a resident, and I'd work all night in Detroit. I mean, Detroit was always busy, right?
Yeah.
Wherever you were.
Yeah.
And you would rarely get any sleep, but then you'd work all the next day. Wow. And especially in surgery, we would work all the next day. The 80-hour work week restricted you from the perspective of, okay, if you were on call the night before, I think initially you were supposed to be done by noon the next day, right, and take the rest of the day off, which as a surgeon is difficult to do, right? Because
especially what happens if you're involved in a case, in the middle of a case? Do you have to hand it off to somebody else?
Yeah, or you would leave, or you wouldn't start the case, or, I don't know really what the residents are doing now, but I was lucky where I didn't have to do that, because right, I think if you want to be good at a skill, and if you ever read Malcolm Gladwell and the 10,000 hour rule, if you want to be good at a skill, the more you do it, the better you will be. So the more surgical cases you do, whether you're with an attending that you like or don't agree with, so on and so forth, the more you do, the better you're going to be. And that's with any.
Makes sense to me.
Any career, right?
Exactly. Any trade, for that matter.
Yeah.
The more you do it.
Yeah. And it was good, because then it set me up when I went into fellowship. Training is a lot different than it used to be. So the goal of going into fellowship, and I had a 2-year fellowship for vascular, thoracic, and cardiac surgery, and the goal was you were supposed to have all the skills, all the knowledge you needed, and those 2 years were just to sort of streamline your skill and for you to actually learn how to run a practice. And that is what I did.
Oh, that too? You had to learn how to run a practice too? Yeah.
I had 2 mentors that were in private practice that I worked with, that when I was in the office, I ran the office, I learned how to run an office, wow, so on and so forth, and take care of patients and all that, as well as doing the surgeries as well. So,
wow.
So a little bit different. I don't think the training programs are the same as they used to be, because then when I got out into practice, I was ready to go. I was ready to go. Like, put me in there. I'm tired of being a resident.
You wasn't stuck with doing one lobe or something.
Yeah. You did your own cases, and you're scheduling your own cases, and And we were a very busy group. You know, we were a huge group in Southwest Michigan. We covered 5 hospitals, and there's only 3 of us. And I was the only thoracic surgeon that was non-cardiac in Southwest Michigan.
Well, Southwest Michigan, that's near where I talked about
Yeah,
before,
yeah,
Niles.
yeah.
That's over by Niles.
Yeah.
In
'Cause-
Harbor, what is it? What's the name of the town there?
Well, I worked out of Battle Creek and Kalamazoo and Marshall, that whole
Okay,
area.
yeah, yeah.
And then even the smaller hospitals like Sturgis and Hillsdale, which are more southern, near the border. So we had a huge practice, and I pulled from about 1.5 million patients within that area.
Right, the population in that
Yeah.
area. Yeah.
And so we would, as a single surgeon, so to speak, I would do about 600 to 700 cases a year. So we had a huge volume in that location. So you needed to know, you needed to be out there and do it, and it was great. We were very, very busy. Very busy.
When you were in high school, what did you think about you wanted to be a doctor back then?
Actually, I wanted to be an oral surgeon to start with.
Really?
Yeah, I actually looked at dental school in Detroit and went to their anatomy class and everything, and that's when I decided to be a physician and go to medical school instead. But I actually went into medical school initially to do forensic pathology. So,
really?
Yeah, and while I was in
Oh, that
medical
sounds creepy.
it's fun.
It's fun.
Yeah. If I had to do it all over again, I actually would have stayed on that path.
Well, nobody's
but
arguing with you, that's for sure. you got no
Yeah,
you got no complaints,
there's
right?
there's no stress, you know.
No.
You know. Unfortunately, you still do pull call, so
Still
you
do
don't
what?
really pull call like. You know, as a surgeon or as a physician in general, you have to pull call, right? So you.
What does that mean, pull call?
You're on the pager during the night, you know,
Oh,
taking
call.
Pull
I thought you
call.
were poking holes. That's what I
Oh,
thought.
pull call.
That's your Michigan accent. That's
Yeah.
your Midwest accent.
I didn't know I had an accent.
Everybody from Michigan says that. But actually, I think you're the best speakers. I think the people from the Midwest are the best speakers. Johnny Carson was from the Midwest.
Yeah.
Who's the other guy the other late night guy that left years ago, got the big beard now? Letterman.
Letterman,
Letterman.
yeah.
He was from the Midwest.
Yeah.
Jay Leno was from right here, Massachusetts.
Oh yeah, that's right. Yeah. I don't.
And actually, he has a house in Rhode Island now. He has a house in Newport.
Oh, okay.
Yeah,
Nice.
that's where he has
With all
a
his
bunch
cars.
of his cars. Yeah.
Yeah.
That's where he got burnt. Did you see him? The fire? He burnt his whole face and everything.
Oh no, I
Oh,
didn't.
the gas exploded in his face. You know, it lit up, and yeah, his whole face got burnt.
Oh, ouch.
Yeah, it was, last summer.
Oh, okay. I
last
didn't
fall.
even know that.
Last fall.
I didn't even know that.
Yeah.
Oh wow.
If you go online, you can see the pictures even. Yeah, the pictures are online of him in the hospital laying like this. And I know what that's about because I got burnt as a kid when I was 6 years old. I playing with matches. I found a box of stick matches. I just turned 6 years old a couple weeks earlier.
Yeah.
And I'm in the backyard and I find this little box of stick matches. And I start lighting the matches and woo. And I found a plastic toy, a little toy soldier. So I melting the toy soldier and watching him trip fire, right? Well, unfortunately, caught under my pants. And before you know it, I'm running around the backyard on fire.
Ouch.
And if it wasn't for the fact that back in those days, most of the houses had, instead of wall-to-wall carpet, you had a oval braided rug in the middle of the floor in the living room.
Yeah.
Or under the kitchen table even.
Yeah.
And my mother and a lot of people put it out on the line. They'd whack it with a baseball bat.
Yeah.
You know, to get all the dirt and dust out of it, right?
Yeah.
Well, she come running out. I'm running around, which is the worst thing to do because you're giving it more life.
Air. Yeah.
And she grabbed the thing off the line. She had the wherewithal to take the rug off the line, throw it on the floor, on the ground, and throw me on it, and then roll me in it to put me out.
Yep. Well, how did you do? I mean, after that.
I spent 6 months in the hospital,
Ouch.
and I couldn't walk for 2 years.
Really?
Yeah.
You've had quite the.
Yeah, exactly. I'm a medical miracle. I got real lucky because in the hospital that I went to didn't have a good reputation. In fact, it closed down a few years ago, right here in Pawtucket.
Yeah.
Well, actually, we're in East Providence, folks, but in Pawtucket, where I live. But lucky for me, there was a world-renowned plastic surgeon a burn surgeon happened to be in the area, and he treated me.
Oh, wow.
Most of the time I was there in the hospital.
Wow.
So that was better for me, I guess. That made it all work. And I ended up walking.
Wow. So a lot of physical therapy or
Oh, God, yeah.
as a kid. And
Yeah.
a lot of risk, like contractures or scar tissue.
Well, the worst part is when you're 6 years old, you get scar tissue. Scar tissue doesn't stretch like normal skin does.
Yeah.
So as I'm growing up, I was in constant pain.
Yeah.
All the way to my late teens, 18, 17, 18, when you're still growing.
Yeah.
That skin's trying to stretch and it ain't stretching. It stretches, but not like,
Yeah, yeah.
and very painfully it stretches.
Yeah.
So
Ouch.
always in pain. And that's why I could handle the pain, I guess.
Yeah, yeah,
When,
for the
when
knee.
that happened to me.
Yeah, 'cause you're so
you
used
you
to-
ask him what he said to me.
Yeah.
He said, I've never seen anybody, I can't believe you did this, not for a day, never mind 12, 14 months
Yeah. Yeah.
in pain like that.
Wow. Interesting.
Now, where do you think healthcare is going to in the United States? Do you think it's going towards socialized medicine?
I think we are making changes, or we need to make changes. We talk a lot about getting away from the fee-for-service component and going more to a value-based care.
Yep. Go more to the what?
And, because fee-for-service really just sort of promotes more cost elevation in patient care. And if you look at value-based care, or really more quality care for patients and patients' health, what you want to focus on is health maintenance and prevention. And obviously, as a part of the Affordable Care Act, we already have a lot of free preventative medicine that is out there, but we want to try to promote more value for patients, and rather than the fee-for-service.
What do you mean more value? Meaning what?
So more quality. So focusing on their health maintenance. So instead of getting so sick that you end up in the hospital and now your treatments are so costly, trying to focus
out what's
more
going
on your health and preventative. So what we already do as far as, mammography and colonoscopies and a lot of female medicine, preventative medicine for that. And what we do, like just within our own practice, and what a lot of systems do for lung cancer screening programs, finding lung nodules early, treating people early. So really focusing also on, diabetes management early, controlling eating habits and obesity, because we have a huge obesity rate. So focusing more on health
That's all
maintenance.
over the world, but mostly in the United States.
Huge in the United States.
I've done a lot of traveling, and you go to Asia, and especially Europe, more so Asia, they're thinner because of the diet.
Yeah.
And the Mideast diet that's in India and Pakistan and all that part of the world.
Yeah.
And Egypt, they have that kind of, in Morocco.
Yeah.
I've been there, and that's all you see in the marketplaces. They've got all beans and all kinds of different vegetables.
Yeah.
Right?
Yeah.
They don't
Rather
eat
than a lot
meat.
of fast food or things of that nature.
Oh yeah, fast food is the big killer, right?
Yeah. 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 Supersize me. Yeah. But I mean, that's what you want to focus on, right? Is more preventative care to help people stay healthier, actually have good health and a good life. But I think the other component, though, is you do have to hold patients accountable for their own care as well. A lot of people don't do their preventative medicine, don't follow up with their doctor, don't do their yearly exams, don't do their mammographies, don't do their colonoscopies, and so on and so forth, don't take care of their diabetes. And you do have to hold people accountable as well for their own health care, I think. But we definitely need to change
You're
how
almost like a
we're doing
babysitter
things.
when you're seeing them, aren't you? When they come in and see you, and you're saying to them, look, you got to do this, you got to do that,
And they don't do it.
they don't do it. You got to wash them.
Like talking to a brick wall.
Exactly.
Well, yeah, I mean,
Like yours truly.
Yeah. Yes. Well, like you said, you stopped smoking many years ago, but I have patients that as a part of our lung screening program, a part of that program is you have to have what's called shared decision making, and you have to do tobacco cessation counseling. And again, sometimes it's like talking to a brick wall.
Right.
You know, we have all these things to offer to help you stop smoking.
And now it's a lot easier. When I quit, they didn't have the patch.
Oh yeah, because you quit in '89.
Yeah.
Yeah. Yeah, so now you have, you have different medications, you have Chantix, which, you know, most people don't tolerate because of the nightmares and those
Yes.
side effects with it. But you have the gum, the nasal sprays, the patches,
Right.
so on and so forth. But if you look at the studies, though, the best way to stop smoking is being mentally ready and just stopping
stop.
cold turkey.
That's how I did it.
The
Just
people
stop.
that are most successful just stop
Yep.
cold turkey.
Yep.
And
You're kidding yourself if you change cigarettes or you go to from a non-filter to a filter, or if you
Yeah,
go
it
to a
doesn't-
smaller
yeah.
cigarette. Or,
Yeah,
You're
yeah.
kidding yourself.
Yeah. The second most successful is the nicotine patch. And the worst, and there was a trend for a while doing the e-cigarettes, those are actually the bottom of the list.
Really?
They don't really change behavior or help you stop smoking. So those are the least successful statistically. So
Wait a minute, is that the vaping stuff?
electronic cigarettes are a little bit different than the vaping, but similar, yeah. I mean, the electronic cigarettes are giving you a water vape with nicotine. So they're giving you the addictive chemical
Right.
from the cigarettes without all the other chemicals.
Yeah, but you're not stopping because you're still addicted,
Right.
right? So it's not putting you out of it.
Yeah, and you still have the same behavior.
That's why it's on the bottom, right? Yeah.
Yeah.
And what does the vaping cigarettes do?
Vaping
What do they
is,
use?
there's still different chemicals or flavor. I mean, there's a lot of different ways to vape with different chemicals or things that they still have in them that can cause acute lung damage or inflammation or pneumonia. So I have a lot of young people who end up in the hospital
Yes.
with pneumonia because of vaping. Same thing with marijuana use. We know now, based on old studies, smoking marijuana does cause lung disease, like emphysema,
Yes,
COPD.
exactly. I've told people that and they think I'm crazy.
Yeah, and there's a new study out as well that now is correlating marijuana. Like, we could never prove if smoking marijuana caused lung cancer, but we're now seeing that, yes, we can start to prove that as well. So,
Well, probably because there's a lot less people smoking cigarettes and a lot more people smoking marijuana. So now you're seeing the people that just smoke marijuana
Yeah.
and don't smoke cigarettes anymore, and they
Yeah.
still get lung cancer.
yeah. I mean, it's interesting trying to, like I said, we're boosting our lung cancer screening program at South Coast again, or reboosting it. So a lot of things sort of changed during the pandemic, and a lot of people not getting care during the pandemic, fearful to go to the doctor or the hospital because of the fear of getting COVID, right? So a lot of people didn't do their typical scans or screening and so on and so forth. So we're revamping or re-promoting our lung cancer screening program. Because the whole point of that program is to find that lung nodule early, so when you do have it, we're
Right.
intervening early. You're
And get
finding
it
a
out.
lung cancer earlier, so on and so forth.
Right.
So we're, and a part of that is, the marijuana cessation, tobacco cessation, stop vaping, stop doing all these inhaled, or protect your lungs from any inhaled chemicals occupationally, so on and so
And it
forth.
seems like these people that do vaping, they inhale much more than a person that smokes. Certainly a lot more smoke comes out of their mouth.
Yeah, and it's definitely creating the same damage, right? Obviously, we, like I said, we see a lot of people, young people, hospitalized because of lung damage or acute lung injury and pneumonia related to vaping.
But they used to advertise, the American Lung Council Association used to advertise, oh, quit smoking, your lungs will go back to perfect after. That's not the case.
No, it's not the case. I mean, anything you do as far as an inhaled product that damages your lungs, if you stop it, so if you stop smoking and you already have emphysema, you will be able to stop the process as long as there's no repeat damage, but it doesn't heal. Like, your lung does not regenerate like the liver regenerate. I mean, your lung just stays, okay, this is where you are. You may not get worse, type of thing. If you stop smoking now and you have bad emphysema, you're on the border to needing oxygen. Well, okay, if you stop smoking, you may get away with not needing oxygen. Your lungs will, stay as is.
But they're not going to clear up.
They're not going to get better, no. I I mean, you can see, like, we get some people into like a pulmonary rehab type of program, you know, exercises for the lungs, so to speak, where you can strengthen your diaphragm, your chest wall muscles, your endurance, your exercise capacity, where
Right.
you do breathe better, and you can keep somebody off of oxygen with some of those programs as well. And again, a lot of those programs were closed during the pandemic, but we're all reopened now, or some of them are limited reopened.
And what do you think of the mask? Do you think that mask actually stops the pandemic, or stops?
Well, I think right now we've already proven, and there's a lot of articles out there now,
They're saying it
that
didn't.
the current Omicron variant, the mask is not really helping.
Not
So,
helping.
Yeah.
Because I have a friend of mine that's like ridiculous with it. You know, he would. I'd go to his house to drop something off. Whatever. He's got the big long thing, and you know, to take it, like pick up a can or something.
Oh, okay.
And he's
The
got the mask
grasper.
on,
Oh, okay.
and he's got the shield on, and oh my God.
That's one extreme or the other, right?
Oh yeah, way too far,
Yeah,
way
yeah.
too far to
Yeah.
one side.
No, I think for some people it was definitely very, very scary. And, you know, I always think going through it, and it feels so weird because it feels like it was so long ago, but going through it at the time, you know, my career, my life, and nothing in same thing, you know, my physician assistant and I will talk about it, nothing changed for us. We still went to work every day. We still saw patients every day. You know?
Did they make you wear a mask?
Yeah, well, in the hospital setting, you still have to.
Really?
Yeah,
Yeah.
even in our office for the state of Massachusetts, in any healthcare facility, you still
Oh,
have
right.
to.
Oh, that's right. You're a mask.
Yeah.
I'm thinking
We
you're
still have
still
to.
in Michigan. Yeah.
Yeah, yeah. There's other places. Well, I think Rhode Island, you may be a little more lenient in the office setting where you don't have to wear a mask. The state of Michigan, like when I go back home to take care of my mom, they definitely don't have to wear masks. So it's different from state to state. Still.
Sure.
Yeah. Yeah.
Yeah, our state was pretty tough on it. Rhode Island was pretty tough on it.
Yeah. Yeah. So.
A question about the smoking again. I've heard that the worst kind of cigarettes to smoke are menthol cigarettes. Is that true?
Well, the unfiltered ones. I mean, any cigarette is bad.
Yeah. But I
It's
mean,
bad.
the worst of the worst.
But as far
is
as
a menthol
getting-
cigarette?
Yeah, as far as the chemicals and being unfiltered
Right.
and so
Well,
on.
they're filtered though. Menthol cigarettes are filtered
Okay.
cigarettes.
Yeah. Sure.
Never smoked?
No,
Never?
no. No, I didn't. My dad was when I was growing up, and a lot of my relatives. So more secondhand smoke, I guess.
Right.
But I never did personally. No.
Your brothers, did they smoke? No?
No.
They're all health nuts, huh? Wow.
Yeah, they
They're all
are.
healthy. What do they do, by the way? What do your brothers do?
Both my brothers are engineers.
Nice. good.
Mechanical engineers. They are health nuts. I think my older brother is definitely very much into biking and races and
Right,
things like
yeah,
that.
yeah.
My other brother is sort of into biking, but he's just more active. But we all work a lot, so there's only so much playtime you can have. But they are very healthy, very active.
Well, that's great. That's
yeah.
great. You sound like you come from a good, well-rounded family.
Yeah, I came from a family of educators, actually. So my dad was superintendent of schools in North Branch for 32 or 35 years. And a lot of my family members and cousins are all teachers
Right,
or
yeah.
principals, you know,
Yeah.
all education or engineers. I'm the only outlier, I guess.
But that's not a bad
Especially-
outlier. That's not a bad outlier.
No, it's the classic family. They ask you for advice, but then they don't follow it. So, so it depends. But yeah, and I'm the only one who also lives outside of Michigan. So I'm definitely the outlier.
So getting back to the robotic surgery, which you are, I hear real good things about you. I heard you're at the top of your game in the robotic surgery.
Yeah, I've been doing it a while.
Yeah.
Yeah.
And I do know about the Da Vinci robot. A little bit, only a little bit. Just
Yeah.
enough to get stupid about it. You know? Just trying to talk about something I know a little bit about. But
Yeah.
and it makes sense that the robot would be better than having somebody's hands in you.
It's the newer equipment is definitely nicer for inside the chest. Well, for any robotic procedure, but definitely is nicer. We are also adding the ion robotic bronchoscopy to our hospital system, which will be up and running next month, which will be nice. It's a type of navigational bronchoscopy. So for any lung nodule in your chest, we can now get there more easily with the robotic equipment.
Right.
So same, also from Intuitive Surgical, different type of platform a little bit, but still robotic, where it's all done from the inside of the airway and inside the lung tissue.
Do you know that when I was working for the governor, we went around all over the state going to different businesses, and I didn't realize there are 3 robotic companies in Rhode Island that make robots in Rhode Island.
Oh,
3,
okay.
3. I was
Oh, I
shocked.
didn't know that.
I was shocked to see 1. We went to there was 3 of them.
Oh, really? I
Yeah.
did not know that.
And
That's
we're
pretty cool.
talking to the boss at this table one day, and all of a sudden I feel something on my shoulder. I look up, and one of the guys had worked the robot, and he was climbing up on the hands.
Yeah.
Not hands,
Yeah.
but the
Is
instruments.
it more for robots for car companies or?
No, these were, I think what you're talking, what you're
more
about.
medical
Yeah, I
robots?
think they're medical, yeah.
Okay.
At least 2 of them were. One was bigger robots, but I know what you're talking about for the
Yeah.
flipping the cars and put the fenders on.
Yeah.
No, these were more detailed robots.
Oh, okay.
I don't know the brand names, but I know one of the companies was owned by a Japanese company.
Oh, okay.
One of the companies, I think it's in Cranston.
Yeah. Yeah, no, it's definitely the way of the future, right? I mean, it's even probably 15 years ago when I went to a conference, they were talking about robots being able to grab their own instrument and exchange the instrument for you
Right.
without having an assistant at the table.
Wow.
You know, obviously I still have an assistant
Now what
at
happens
the
if they
table.
drop it though?
Get another one? No 5-second rule. You
No?
can't pick it back up.
No, you can't do that?
You gotta get another one.
So you always have a couple of each on the table?
In the room, we always have a spare, so to speak.
Right.
Like if one gets contaminated, or they only have so many lives, right? So if you're using, for example, a stapling device, it has 10 rounds or 10 lives or
Right.
10 fires. So once let's say I'm doing a larger surgery where I'm using the stapler all the time, sometimes I have to do 2 of them, because after 10 fires, it's done. So you can't use it again. Same thing with some of the other instruments where across the board early on, it used to be 10 lives for any instrument, be it a
Right.
grasper or a needle driver to suture, so on and so forth. But a lot of those now are more expanded to 15 or 20 lives, where you can use the instrument more often.
Well, I got to tell you, this has been an interesting hour. Do you know you spent an hour with Bob? Do you know we've done an hour? Do you realize
no,
we
I
have
didn't.
talked an hour?
I didn't know that.
Yeah, we have.
It's either a good hour or a bad
Hopefully
hour.
you have talked most of it, thankfully, gladly. Yeah,
Yeah.
very, very interesting.
Yeah.
It was as impressive or more impressive than I even was told about you.
Oh, well, thank you.
So I
Thank you.
appreciate it. Dr. Tammy Gleeson, huh?
Gleeson.
Gleeson,
Yeah,
I'm sorry, Gleeson. And do you know why I said that? That's the
No.
doctor I got to go see tomorrow, Gleeson.
Oh.
That's my hot doctor. Gleeson, Tammy Gleeson. Well, thank
Close.
you for spending an hour, a whole hour with
A
Bob.
whole hour, yeah.
You did a whole hour.
I made it through.
Yeah, you did. Was it that bad? Did it hurt? Was it like a surgery?
No, it wasn't painful at
It
all.
wasn't painful at
No,
all? Didn't
no.
hurt? No recovery time?
No recovery
All right,
time.
we got it.
All right,
Well, thank you.
thank you.